Nginamukele futhi kwezempilo zomontakalo. Namhlanje sikhuluma ngodaba olubalulekile njengoba bengimbingelele ekuqaleni ngezandla ukukhuluma ngezandla lokho sikubonza kakhulu umuntu uma hearing loss noma lokho sithi abantu badeaf abeva etindlakeni. So namhlanje kwezempilo zomontakalo simphathele abantu abahlukahlukene abazobe besichazela kabanzi ngalolu hlelo. Kanti namhlanje futhi angihambi yedwa ngihamba naye umlingani wami uLuthando Phaswane.
Nikolego wa Macheroni botana nzingo kazo mtaka namsiro wa specialist ENT specialist Professor Mashudu Chifularo and Joseph Naidu is a radiologist, and I'm sure you'll give them their panelists and what they do exactly. Because the ENT and audiology, this is the same line of attention and profession and discipline. They will tell us how different it is. And sometimes we go to a Chifularo not only in South Africa.
Asizwele ngaye kahle hle akubani sizobathula sinosisi ukhetha ukuthula wabambatha oyena ke ufundisa ngayo sign language lapha eVet bese siba naye i-pharmacist uMr Iris Gugu naye uzochaza ke kabanzi ukuthi as pharmacist bangena kanjani lapho ukuthi abantu babezwa khona. Prof Chifularo.
Thank you.
Who is Prof Chifularo?
Professor Mashudu Chifularo. I'm an otorhinolaryngologist, which means otorhinolaryngologist, ear, nose, and throat, ENT. And we also mix with what we call head and neck. So most people think we deal with the running nose and wax and tonsillitis, but the specialist is very wide, and sometimes the specialist can be divided into adult and also children, peds, which we call peds otorhinolaryngology, like when you have pediatricians. So Mashudu Chifularo, I come all the way from Venda in a village called Mbaera, and I'm born and bred in South Africa. I live in the past 2 to 3 years since 2019. I've not been very active in social media because I do not know social media that well, and I didn't want to get into trouble by saying I'm not supposed to say. And some people will say, no, it's not from South Africa, it's from Kenya, it's from and some reason it doesn't exist. So I told them, look, Plant was there, so I do exist. I come from a family of doctors. We have 3 doctors in the family, but all in all, including our children and partners, we are 8 doctors. So and 2 professors. So I have my younger brother who is also a professor. So when you call Dr. Chifularo, you have to be specific. So I prefer to be called by first name. So if you just say, I'm looking for Mashudu, it's more than enough. I have many crowns, I have many titles, but I can't allow my student to call me that way. I'm at the University of Pretoria, and also State Biko Academic Hospital, that is where I work. And that is where I did my groundbreaking operation of middle ear transplant, which is replacing the smallest bones in the body, as compared to the hip transplant, which is also the biggest bone in the body. So I deal with all ear problem, but more specifically, I'm what they call otology, and also PSORL, because I love hearing and deafness and restoration.
Bo remember look well the Mashood. Very well Mashood. Now Muslim. Now Mashood is flat. Now Muslim. And during Israel's Bamba Mashood, was it auto riding? Man, because you know some of these things. This today, but we are not about our baby girls or it's cool and again. Or I'm also there, you know, the auto riding and so my Jete, so I'm saying, Jete, no, your touches in our Ruba Zulu has in there, Gamanda never was Chacono. Who Faran, who Tomari, Gamari, can't you tell what about Venana in the Bible? That was the Garan have the hands in there. I've been as well, so to Mama, wait a minute.
The problem of deafness, there's a difference between hearing loss and your audiologist will tell you difference between hearing loss and deafness. Because hearing loss, you might be, when we test, we find that your hearing is not within normal, but you're still functional. But when you become deaf, it's when you are disabled. That's why there's a community where they call deaf community. So there are people who said, look, we were born deaf, and we don't want to be changed. We live like this. All we can do is sign language. And they live like that and they're happy. So they accept whatever God has given them. Interesting enough, the organ of hearing, which is the cochlea, because the hearing is outer, it's middle ear, which is the straight bone. So, and then you come to the cochlea, and then you go to the brainstem, then you go to the brain center. So therefore, whatever you hear, it gets processed in the brain, both sides, because when you get into the brain, it crosses over immediately. Thanks to the man above, we don't know how it happened. It crosses immediately, and you can hear which side am I talking from. We are unlike animals, where animals, they move the ears. With us, you have to do this to get more sound to come into the ear. So the question where you ask, when does deafness start? In other words, hearing that is dysfunctional. So there are different statistics according to the WHO. They categorize they are according to children and youth, and also according to adults. And it's being estimated that in the coming 20 to 30 years, in other words, in 2050, there will be more than 1 billion youth who have hearing loss. And the biggest problem is the gadgets that we use, that they keep on putting sound in the ear more than 24 hours. They sleep with them. First thing when they wake up, they want their headphones. So the noise-induced hearing loss is the biggest problem. So when you speak about deafness, you have to say either start intrauterine. The organ of hearing is the organ that makes us to be able to contribute largely in communication. Because when you can hear, you can talk with somebody. Yes, I can do sign language as augmenting what I'm communicating. So it's the organ that matured more earlier than any other organ. By 8 weeks of intrauterine, the organ is fully developed, it's fully matured. So I always say to the parents, the organ that's matured more earlier than any other organ. By 8 weeks of intrauterine, the organ is fully developed, it's fully matured. So I always say to the parents, when they're excited and they're playing music, the baby's kicking, it's exciting. But when they get scared or there is fight, the baby just keep quiet. They must know that the baby is here. So you can play music and talk to the baby when the baby is still inside, because the baby can hear. So when the parents, I'm sure some will tell you, when they fight, they're screaming, and the mother is anxious, the baby just keep quiet to say, don't make noise. But when it's relaxed, the baby plays around and everything. So some they go on and put music and talk to the child. They will tell you talk to the child and communicate with the child, so that when the child is born, is familiar to that voice. That's why the mother, even if the child screams amongst many children, the mother can tell that is my baby. So it's the same kind of relationship which you cannot understand. So they can start to lose the hearing from intrauterine. So that's why the doctors will always say that immediately you fall pregnant, the first 3 weeks, the first 3 months are very critical. But for us, the first 2 months are very critical. When you go to pharmacists, you can tell the pharmacist that I'm pregnant. When you talk to the doctor, tell the doctor I'm pregnant. Because there are many medications that damage the inner ear, the cochlea. We call it ototoxicity. And then even when you are adult, after you're born, there's still problem of ototoxicity, just depends. So, and then all other things, some is genetical, some is infection, some is trauma, some is low birth weight, some is hypoxia. The children who are born with poor saturation into the brain. And the worst thing with the organ of Corti, it has only one blood supply. So if that blood supply gets cut, the whole system goes. So it's very, very, very sensitive.
Mr. Joseph, Prof. Yes, he has said a lot about this, especially that the baby can hear before they are born. When we are doing, before we discharge a child and mother after delivery, we make sure that is the baby passing urine, is the baby sucking milk, is the baby passing stools. What do you think we should do or improve as doctors? That also we must make sure that we test that the baby can hear. Because most of the time they find it very, very big that, maybe 7 years, 8 years, that no, my child is not speaking, but the problem is you find is hearing. So, is there anything we can do?
So yes, we can monitor hearing pretty much from the moment the child is born. And it's an objective test, so that there's no actual response required from the child. The child can even be sedated. And the test looks at, there's 2 options. It can look at how the cochlea is functioning, or we can do a special test that looks at how the brainstem is responding to sound, which tells us along the auditory pathway where the problem could be, if it's one ear, both ears, and this whole process can be done within 45 minutes.
Okay.
In the little nursery cubicle, and you can have your results before you move on. Sometimes you get some false positives. If there's still fluid in the ear or vernix in the ear, it may complicate the results. But usually, if that is identified, then we retest within the first month. And the focus is always on early identification, because if you can identify it early, either depending on the parents, we can go for management, or if the family feels that, you know what, it's at the hearing loss is at a point where even with intervention, the child will still be classified as deaf. We would like our child to fit within the deaf community, and then there's a slightly different approach to how you would manage that. There's organizations that assist in terms of migrating the family and the child into a deaf focused environment where sign language becomes the key focus of communication, as opposed to looking at cochlear implants or hearing aids to assist with residual hearing.
Just maybe as a follow-up, because I wanted to say then, Prof, do we have a situation where we have this kind of multidisciplinary approach I know the funders might have an issue regards a gynae patient, or a child, why should she be seen by an audiologist at the early stages? But from what he's saying, it's very important. Or any or a hearing problem or something that is not going right. How is our system to that?
I think the other thing that I want to add from Mr. Dr.
Josiah
Snyder is that neonatal screening. So within a month of birth, they are supposed to do testing the hearing before the child leaves the hospital, or within a month. But by 3 months of age, they must be aware that this child can hear or this child cannot hear. And there's also genetic components. So they are high risk. He will tell you that we know that a mother who is expecting high risk child maybe is going through genetics, so it's in the family. So that's why you find that if it's familiar, then we know straight away. And sometimes that the mother might be very sick, that we don't have a choice but to give medication. So we have to wait to say, look, we are praying that we won't damage the hearing. But the current thing now, like if you go to tertiary hospital like Steve Biko, I think UCT, I guess even vets, I'm not sure whether other place, some private school they do neonatal screening. So immediately when the child is born, they go and do acoustic emission. They just want to check the sound because it's what we call inner hair cells and outer hair cells. So even if we know that the bigger carrier of sound is the inner hair cells, but they have all different tests that they can do immediately.
Can we go to those tests, Joseph?
Yeah. So, as Prof mentioned, the first type of test you can do is called otoacoustic emissions, and that is a very simple test where they put in a little probe into the ear that produces very soft clicks, and then the probe also listens out for a response. So it's almost like you drop a pebble in the water and you're looking for the ripples. That's what the otoacoustic emission does. It stimulates the ear and then it waits to see if there's a bounce back, if there's any movement of those inner hair cells, which tells us if those hair cells are actually functioning normally. Again, usually it's sensitive at picking up high frequency hearing loss and anything above a mild to moderate. So it may miss a very slight hearing loss, but the focus is on identifying something that may be a problem for the child going forward. Then the second type of test that we can do is called auditory brainstem testing, or ABR. And that looks like at connecting electrodes to the child, presenting sound through earphones, and then the electrodes look at the brainstem response or the neural firing. So the ear processes the sound and it sends a neural impulse to the brain where we actually hear it. And this test actually picks up that little response. So it tells us the sound went through, the eardrum did its job, the cochlea did its job, and the neural system or the auditory nerve is actually processing the sound, which basically indicates that pretty much the whole pathway is functioning normally.
Right. And also to add on him, so when we say a person is deaf, it does not mean that one size fits all, because you might get a person like a child. A child is a sound that they do, the normal sound. They're just stimulating the system. But you might find that the brain center, it cannot process what is hearing. That's why when you get somebody who has a stroke on the processing center, they can hear but they cannot speak. And then you get a child who has all the system working, but they cannot speak because they have autism. In other words, the receiver received, but the producer or the thing that led them to be able to speak is not functional. So therefore it's very, very critical that if you, for the small children, you won't know. With them, when they do otoacoustic emission and all the rest, they're just telling you that the child has failed or the child has passed. Even if those the high risk features has been determined, you have already premature baby delivery. If the mother, when they were pregnant, they have a lot of infections, like we're talking of diabetic and hypertension, hypoxia, and one of them, most of the baby when they are born, they have jaundice, yellow babies. So the first thing we said, was your child yellow in the machine and getting medication from ICU? Then we know that that is a high risk child. By 3 months, they must repeat it. Then they do what they call diagnostic ABR to make sure. But the point I want to show to the listeners is that when we say somebody cannot hear, it does not necessarily mean that is the outer ear, middle ear, or cochlea, or brainstem. It could be the center. So the person, and it happened that, but when you go for tests, you pass. But this person said, I can't hear. It's almost like when somebody speaks a foreign language. If I speak Venda here, and you're not a Venda speaking, you won't understand. You just see that this person is just making sounds. So the assessment between the audiologist and the ENT specialist is very critical.
And to go to Prof. Murababa Mara, Babuzumranda, like audiology stuff. And I'm hearing some tests. My head is spinning currently. I don't know if I were a neurologist father, because importantly, so I'm talking about story, but I cheers Pandela, Anchiaka, audiologist, KNT, I did the test in Nezapanu. I'm for it. For man, people man know what to test here. I couldn't do sell and those for as you want to catch Manzina had to translate or but it's something that I feel like we need to teach or educate people more so that they get to. I'm a healthcare professional. I'm struggling to wrap my head around these words, and then I'm thinking, are there no other simpler words in ENT and this audiology and things that we can throw, you call it around Marshall in Newcastle, in Newcastle, because what kind of specialists are calling Newcastle? I mean, I'm most of my friends they were being so I know we have produced quite a lot of people from that side. But me as good. Nivajack and this is sure that Amaka, because it's never translated easily.
Like audiologists, the audiologists, that will be the side.
Oh,
so
yes,
the and then doctor, professor, and it will be depending on the special
umntwana sisemncane ungafundiswa kanjani abazali ukuthi ukulungisa
khona kuba yinkinga because 90% abantwana bangezwa bazalwa emafemelini abazwayo so uyaqala ukubona into ongakhuluma so kuba nzima for labo bantwana because then okusho ukuthi brain development yakho when it comes to language ayikho until the time you have your spoken deaf or the time until the time you identify usunenkinga angezwa so then kuba lula if umntwana ezalwa if abazali abadeaf naye njengaye so then bona from the word go they sign njengoba mina umntanami ezalwa njengamdlalisa onanazi into so now they do the same but they're using sign language so loyo mntwana already language ubafika ukulala ungalula for yena because khona common networks that happens in your brain as umntwana efunda language. So if umntwana deaf akana stimulation, then lawo networks lawo awadevelophi emongeni wakhe, then kuba nzima, then yeah.
Manje ukuthi le language njengoba sobafundisa ngezandla, ngifuna ukwazi la ukuthi kubantwana, especially abantwana, abomama bakhona, kufanele bona uyaqala ukuthi umntwana namhlanje umama ngokwazi ukukhuluma. Sefanele benze njani lapho bazali abasekhaya namhlanje abanomntwana aqeda ukuzalwa akakhulumi. Kufanele bahambe baye esikolweni bokufundela ukukhuluma ngezandla. Kufanele benze njani?
Okay, and that's why we have organizations like High Hopes, where Josias naye unosebenza nabo. High Hopes is the organization that helps abazali who give birth to abantwana abadeaf. Ubasiza ukuthi baform that bond and communication nabantwana.
So support
akhona associations and organizations that helps abazali like ODEFSA, there's OSANDA. So those are the organizations you can actually contact and get help and one another. But then back referring to Ezimindawo, something to crash, and most schools now they do offer sign language classes for parents and families of abantwana abadeaf. So yeah.
But kethu asibeke simuntu omnyama ngiyazi ukuthi makunomntwana ongathi akezwa kahle or akakwazi ukukhuluma whatever the situation, thina sithanda ukuthi hayi bamthakathi benze lo nalo. So wena njengoba uthi uze ufike kule stage ukuthi ufundele enze izinto zamasayina wayithola bese-Newcastle boshobe basho ukuthi hayi bamthakathi sometimes I'm keep ending because that's how the community is routine.
Communities in our black communities, we have that siloyiwe thing, most of the times. And mina, sign language ngayifunda when I was still doing rehabilitation for abantu blind and deaf blind. So I was doing a training, independent and stuff. So then I worked for an organization in Durban that had deaf and blind together. So then that's when I learned sign language for the first time.
So what
ngaqala somewhere ngabangaboni. So rehab yabo. Then ngase ngathola lo ongadeaf. So ngase ngathi okay, so I learned later ukuthi I can actually do this as a profession. So which then I went to a university to study a degree in language practice that had sign language and interpreting and translation and so on. Yeah.
The important thing that she mentioned that I want to add to the family, there is a critical age that by that age you must know if the child can hear or not before we send them for sign language. And so it's also to go also with the cochlear implant. So by 6 months of age, the audiologist must be able to have done, and the ENT to have done all the tests. Because sometimes we get patients who come almost 10 years. So after 3 years, between 3 and 5 years, then the brain starts to die and it does not develop. So it's what we call a prelingual deafness. So in other words, they never spoke. Then there's postlingual deafness. The postlingual deafness, the center for speech, it has developed. It's easy to remind things, like even when we do cochlear implant or when they rehabilitate. So I appeal to the parents that there are a lot of children who are in the special school for deaf who are not supposed to be there. So which means that as early as you suspect that, you tell if the child cannot hear. When you open the door, the child doesn't respond. When you watch TV, the child doesn't respond. When you play with other people, with other kids, he's very aggressive, he hit them because he cannot hear them. He is in another world, he's frustrated. But within the first 3 years, please consult, see the audiologist, see the ENT, do all the investigation, and in the tertiary institutions, like I said, place like University of Pretoria, Wits, Stellenbosch, UCT, and place like Sfakumakatu. They'll do all those tests and they'll tell you that, look, this child, the Center for Hearing is not developed. So there's no way that we'll be able to rehabilitate either with hearing aid, middle ear implant, or cochlear implant, or brainstem implant. This child must just learn sign language. Other than that, they must encourage to speak, because the cost of not rehabilitating a deaf child is very, very, very high. So studies show that if the child is implanted within the first 3 years, they develop properly like any other child. They don't remain behind. They can attend the normal school. It's so said that when we come to hearing aid or to hearing rehabilitation, people are ashamed. So when you have a hearing aid, they say, no, you are not intelligent. There's no such a thing. There's no such a thing. And it can happen anywhere, anytime. You can get meningitis and your hearing goes. The pharmacist can give you the medication and then your hearing just disappear immediately. So, but for children, as we're talking about sign language and when to decide, the first 3 years are critical. Don't delay and delay and delay and delay and delay and delay.
Thank you so much, Prof. Mr. Idris, there are a lot of pharmacists who can show us some of the metric or high more key pharmacists, the just pharmacists.
Okay. Good afternoon, viewers. A pharmacist is a drug specialist in a nutshell. So, but a legal drug specialist. So obviously, you go and study a degree at university. And it takes about 4 years to complete the degree, and you do your community service, and then afterwards you do your internship, and then you are registered as a pharmacist to practice clinically in any area of pharmacy. So so that's what the pharmacist is. And then really our role in the community is to ensure safe use of drugs to the community. You have like your over-the-counter medication, and these are medications which you can buy without a prescription. A lot of them are Schedule 1 and Schedule 2, and some of them are even Schedule 0. Those that are Schedule 0, you normally get them in the supermarket, like your Grandpa, like your Med Lemon, etc., the Compral and things like that. So you still get those as well in the pharmacy, but really the complications that the medicines bring cannot be underestimated, because when people are sick, all the time they are either taking over-the-counter medication and the doctor has prescribed them something else, and there's a whole lot of drug interactions, because some drugs, how they work is that they make other drug concentrations to be high in the body because of the enzymes. They are called enzyme inhibitors. You have those enzymes that are metabolizing the drug and eliminating the drug via the kidneys. So you realize that if you are taking certain drugs, they are actually increasing the levels of that drug in the body. That is why it's important when you reach your pharmacy, even if you're buying your over-the-counter medication, you just explain what conditions do you have, maybe chronic conditions, or even an acute condition when you are treated with other medication. It's very, very important. Or if you are pregnant, etc., etc. That is very, very important, because a pharmacist will be in a position to explain to you how safe it is to take all your medications collectively, and he will probably refer you back to the doctor if there's any critical intervention that has to be implemented, for that situation.
A follow-up from what he's saying, I'm very sorry.
But you're talking about that, and I was sitting here listening to you guys. There was a little bit of a flow. If you take this medication, we are talking more about hearing problems here. Where do you future in, either in prevention or in promoting or whether healing, whatever the problem may be, regards hearing problems?
Okay. Look, this what Prof has mentioned, which is called ototoxicity. Those are the drugs which are causing a damage in your cochlea. Cochlea is that organ of hearing which you find in your inner ear. So they cause either a temporary damage or they cause a permanent damage. And when there's a damage on the cochlea or the nerve supply, then a person or a patient will start losing hearing. And usually it starts with those funny sounds in the ear, like they call them tinnitus. And it's caused by drugs such as aspirin. And if you think of aspirin, it is contained in many medication, as I have indicated. For example, I get a lot of patients coming and saying, even in public, they talk about how they have treated their flu, self-treated their flu. And when you listen to what they are taking, they take in Medlemon, which contain aspirin, almost 500 milligrams. And then they will also tell you that they take it with Grandpa, and Grandpa has got aspirin. So apart from just aspirin being ototoxic, the dose is high. And you get people who are also addicted to taking aspirin because they've got headaches every now and then. So they will take like Grandpa for headache every now and then because it's easy just to put it in the mouth and swallow, you understand? So it has long-term consequences, And the risk is so much. So those are the drugs. And then you also get some antibiotics, mostly like your aminoglycosides. But those antibiotics are normally administered in a hospital settings. You get when people have got pneumonia or septicemia, or maybe complicated urinary tract infection. So in that case, at least I'm more comfortable because they are under a supervision of a medically trained doctor. So they also have a potential to cause ototoxicity. So you can understand once the patient is discharged from hospital, they've got other antibiotics as well, like even doxycycline, for example, and then they start taking Grandpa. So now you have two drugs that are potentially ototoxic. So the risk of you suffering from hair loss is even greater. And it's even worse in elderly patients because of renal problems, like if they have renal compromise and diseases. So because the kidneys, they eliminate drugs. So for that reason, you will find that the chances of them contracting ototoxicity is more. Also, elderly patients, they suffer from high blood pressure. Most of them, they contract high blood pressure, and then the high saline diuretics, like the popular one, which is like your Lasix, they call it water pill. Yeah, people when they've got edema and congestive heart failures and high blood pressure, they use that as well. So it has the potential also to cause hearing loss. But what I'm saying, I'm not saying everybody who's taking these drugs will automatically contract ototoxicity. Yeah, so it depends on genetics, and it also depends on your overall health status, whether you will contract it or not, the duration of exposure of the drug in the body, and the amount of dose that you've taken, and how many of the ototoxic drugs are you taking. So that's really very important.
And the other thing that I want to add is forgetting that our patients, when they come to the doctor, they've gone to all other alternative doctors. And either about traditional healer, they have some roots that they use, or they go to the Muruti, or then they come to you, they try this, they try that. And there are times when you have a patient with a kidney problems, where you want to save life, and the way you said, my friend, your kidney are very susceptible. We get a lot of, some of our specialist physicians, they don't care about the hearing. So they'll just pump them with all this, we call them aminoglycosides. Also, we put in the ears. So that's why we said if you have a perforated eardrums, most of the eardrops are made out of aminoglycosides. You put it there, it just goes straight into the cochlea and it damages it on the spot. So if you are damaged, the perforation or injury, please see an ENT specialist so that we'll be able to advise this is safe, this is not safe. So, and even when they are getting all, let alone the renal problem, patient with the renal unit, chronic kidney failure, diabetic patient, high cholesterol, as I mentioned earlier on that the organ of Corti is supplied by a single artery, end artery. So if the cholesterol block that thing, they're going to lose the hearing immediately. And so if the kidney and the liver is not working well, which when you give the medicine, then they're not going to be able to remove them from your system. And then they're going to collect, they're going to the cochlea, and they're going to damage it. But there are times where we said, you know what? We want you to be alive with hearing loss. We'll treat the hearing loss. For example, you die with hearing. So, we give them that charge. When you give the ototoxic drug that we're talking about, like when you deal with streptomycin for resistant TB, you don't have a choice. You just tell them straight away to say, you know what, this drug is going to hit your hearing. So you must decide. You want to die with your hearing, or you want to be alive and lose your hearing? Then we'll give you a hearing aid. So, and some are permanent, like you mentioned. Some are permanent.
If I stop that streptomycin and other things, will I go back and hear, or it's now permanent?
But it depends which type. So, like the diuretics, they will suppress them a little bit. The non-steroidal anti-inflammatory, they also suppress it a bit, but it will come back. Like the aspirin, it will come back. But if it's also with other ototoxic medication, so if you are taking a medication, all of a sudden you experience a ringing sound in the ear, ringing, not just funny sound, ringing like there's a bell, you must know that you are losing your hearing. You must stop that muti. Yeah, you're not going to. The cochlea is telling you that you're knocking it. As has mentioned earlier on, the same hair cell that they test, immediately when they start to be.
As nurses to Kalusa, Gaga, drugs, they really get ototoxicity. Give us a Kalusa or high, they can prevent this problem now. Maybe the drugs or the treatments, they combine, the right problem in our person to be. They can prevent that problem.
Yeah. Look, it's more about education and education, and where you can get education on the use of drugs is at your nearest pharmacy. So the best thing is that whenever you go to the pharmacy, always be transparent in terms of what other medication you are taking, so that the pharmacist can be able to assess the drug interaction and also the safety of drug and whether it can result into ototoxicity or not, including, as well as Prof has indicated, your traditional medications. We know that these traditional medications, most of them work, but the problem is that they have not undergone proper clinical trials. So clinical trials are there to manage or to assess safety and efficacy of drugs. And that also includes what will be the minimum effective dose, because taking a drug in a very high dose doesn't mean that you'll ill fast. The rest of it leads to toxicity. And if it's ototoxic, like I said, if you are taking one of those, then the more the damage you will experience. So the best thing is really to explain to the pharmacist. And if you find yourself having regular headaches, for example, requiring you to take like painkillers, like your aspirin, or maybe you have arthritis And then you need to take some anti-inflammatories as well, like aspirin or indomethacin, or, in them, the Myprodols, which is usually called R10s. There's many drugs. Then rather consult with your pharmacist, because then there is an underlying condition which pushes you to continuously take that medication. So it means you are only treating the symptoms. You are not really treating the root cause of the problem. So the best thing is education. And then secondly, if you keep on taking treatment repetitively, just make sure that you consult with your physician to really assess what the root cause is for the medication, for the condition that you have.
Masibhekile nje eSouth Africa, zingakanani iy'kolo esinazo ezincedisa abantwana abakhuluma nge-sign language? From primary school, high school, zikhona, zikuphi?
Oh, we have about 44 schools for the deaf, but ezinye zihlanganisa deaf and blind, but nje that caters for deaf people. There are 44 in South Africa, and in Gauteng we have about 7. We have about 7 or 8 or 9 in KZN. We have in Limpopo. We have 2 in Free State. We have in Northwest other schools, but we do have schools all over. Yeah, there are schools also in Mpumalanga, even though they're not as much as they are in Gauteng and KZN. So, but they are schools. But it's just that now the kids, they'll have to stay there because the schools are far. So they only go home on holidays and stuff. Yeah.
Okay. So, if ever, I just want to see what it. Now, as a matric, are they able to, like, a degree, professions, avulekile in South Africa, because I've never seen a doctor or khuluma sign or a physiotherapist or khuluma sign language. Kuvulekile for bona noma. Imaphi nje njenganje lapho ufundisa khona. Imaphi amakhosi no offerayo for bona?
The problem is kahle education yabo in the deaf schools. The problem is the government will hire a teacher who is not a signer, and the teacher is there now to teach these kids, deaf kids, English or maths or whatever. Then the teacher might take like 3 years. It's a sign language. So now you ask yourself, when is learning taking place? Because then the teacher doesn't know sign language, and the school needs a teacher, yes. The teacher is qualified to teach, but not to teach kids who cannot hear. So then the teachers spend more time learning the language from kids, so it's a bit difficult, because then it would be nicer if we have more teachers who also learn sign language, so that when they are done with their degree, then they can go then and teach in the deaf schools. And then what normally happens again is there's no motivation. It's like, are you deaf? You can't. You deaf? You can't. So that's what they hear every day. So most of them, they drop out of school. They don't finish matric. And then also from then up until I think last year or year before, we only then had sign language as a language that you can actually get tested on in matric and stuff. So before, most deaf matriculants would actually finish matric with only 5 subjects. So now access to university is a bit tricky, because you only have 5 subjects and universities expect you to have 6 or 7. So then it means the points, they don't actually allow them to access higher education. And also others would just have matric that is broken into 2. This year they'll do 3, and then, because again, the stigma that you are deaf, no, you can't. So, it's, they need, if you can have more role models of deaf people who are really making it, because up until I think in 2010, we only had about 10 deaf people who had degrees. But no, 30. Yes, we only had 30.
For me, that's insignificant in the number of the statistics that I was hearing. Jengo Uzu, Prof. Anti, men say there are so many people might have schools now that maybe they were not even supposed to be there. And with your experience, having been there, do you think there could have been, cases like that where you see somebody there might have been, sign that they could do better or they have not been assessed properly?
Yes, because most of the people that are maybe I'll socialize with, when you ask, when did you go deaf? They went deaf because of meningitis, others, just different sicknesses. Most were not born deaf, they just acquired deafness later. And if, again, they'll be like, if my mother had known where to take me, I would have been hearing now. But then problem is, information in our communities, it is not that, people don't know where to go. They always think like, you are saying, doctor, medical doctor, like they don't think audiologist, or they don't even know about an audiologist. They don't even know about an ENT. I know about ENT, but I forgot there's an ENT. So I know audiologists because we normally refer our students at the university to an audiologist to get tested if they have problems, they can't hear in class and stuff. So would refer. But people do not know where to go. They just think, okay, I can't hear, I go to the doctor. And the doctor doesn't really take time to do some research on where can I refer this person who is now deaf, or the mother who's just distressed. That's when they start keeping their kids because they feel they are cursed. And
The other thing is that when you look at an illness, usually there's a sign. So there's pain, there's fever, there's an infection, there's pus. With the hearing loss, there's usually none of that. So parents don't see it as a sickness or an illness. And if you go to a clinic or you go to a primary healthcare facility that's not geared out to look for hearing loss, they look for the traditional markers. Oh, but the child's temperature is fine, everything else is fine. You tick, 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 tick. It may just be he something small, and then they push it away because the system is geared to look for infection or disease, and in most cases, as Prof will tell you, there's no sign.
You know what, Joseph, you're saying that and it will immediately trigger something. When I was doing early stages, doing biology, there was hospitals, there was something about balance. And when you're saying they look at it as this small thing, what are the other functions of this system that might be so important that people ignore? Because now that you're saying some of this, I'm realizing there might be other things and they push it, it's just a small thing. And when I'm talking balance and many other things that may be there, it might actually start to look the real issue that it is, because it's an important part of whether the movement or how we're seeing things, how we're hearing, and so on. What are the other functions of this system?
So the auditory system, or the vestibular auditory system, is a twofold system where the bigger part we understand, it's hearing, but the other part, and it's pretty much attached. The organ is not separated; it's one structure. Half of it processes sound, which helps us with hearing. The other half is the vestibular portion that actually tells us where we are, whether you're moving left, right, front, back, up or down. Usually, in most cases, you can have a normally functioning vestibular system even in the presence of deafness or hearing loss. Sometimes certain medications, certain drugs can cause damage of the auditory system and extend into damaging the vestibular system. And in most cases, the balance issue usually presents later on in life. As the body begins to age, people may find that they're getting episodes of dizziness. We call it vertigo, where they feel that the world is spinning around them, or it feels like you got motion sickness. Some people, motion sickness is easier to understand because people say, oh, when I'm in the car, or when I don't go on a boat because I get very nauseous and I start to vomit. And that's because that system is sending a mismatched signal to the brain. So the brain is under the impression that everything is okay, but that system is saying, oh no, I'm leaning to the left or I'm leaning to the right. And then the brain can't always gauge with, and the reason it happens often in a ship or a big vessel is because when you're standing in a ship and you're looking out, your eye is telling your brain everything is steady, because with the whole building or the whole boat is stable. But this vestibular system, because it's so sensitive, it's picking up that mild vibrations, and it's telling the brain, no, we're moving. But the eyes and the legs are saying, no, we're standing straight. And that's when people start to feel this imbalance. And again, certain drug interactions can cause damage to the ear or the inner ear, affecting both. And sometimes treating certain conditions can cause toxicity of the vestibular portion of the auditory system. But yeah, from the outside perspective, the entire system is so complicated and so well designed and put together. People don't realize we don't have these flaps of skin here because, it just happened to be it's not ornamental. It serves every part of the ear. Serves a specific purpose. It traps sound, it directs sound, it can even protect you from loud sound. The ear has protective mechanisms that clip off potentially harmful sounds so that you can hear effectively without causing damage in a natural environment. Which
yes, bro.
It's a beautiful world there. When I get into the theater now with these big monitors, and you put a scope and you see the whole ear inside. Beautiful. And
the love from Prof.
No. And it makes one appreciate that God is amazing. That's why I always say to people, it's interesting that the more we learn, the more we think we know. No, we're supposed to believe in God more, because now He's showing us how complicated and how smart He is. There is written in the one book that I believe in that it said, the foolishness of God is more stronger and better than the wisest of men. So when you look in the ear, like he's saying, we haven't even learned everything. But what I wanted to come, he mentioned earlier the point of referral, which you want the parents to know. Unfortunately, even in our medical training, I've been teaching as a professor now for 22 years. And I was trained as an undergraduate doctor, because for us to be a specialist, you need to go through medical training, the same like neurologist. You go through your 6 years, then you do your 2 years internship, then you do your community service, so 9 years is gone. And then from there you go back and specialize for 5 years. So 14 years to be a specialist.
Soft life goes.
And when you go to medical aid and tell people to say, look, this is the price that I charge, they tell you that you are too expensive. I said, there's no price for your life. But prevention is better than cure. The unfortunate part is in undergraduate training, Josiah, is that we don't teach our junior doctors enough about ENT. So where I teach at University of Pretoria, I encourage them to learn when to refer them. Please refer to the specialist, When the specialist says look and say, look, there's nothing, then you can do whatever you want to do. But the issue of just sitting is that's where my sister here was saying that the brain cell dies and it does not develop. And then they will, as human beings, they will start to learn other alternative way of wanting to hear. So if we're doing deaf awareness to somebody who is watching and listening, is that please make sure that you consult as soon as possible. There's no price for your health. If you go to a GP and you're not happy, general practitioner, you're not happy, go for another. If you're not happy, go to another. You're not happy, go to ENT. You're not even happy, go. There are some where audiologists, they are called doctors, and they claim themselves to be doctors. Ear doctors. But they're just audiologists. They help us to do the test. They help us to rehabilitate the patient. But it's very, very important because the hearing loss can happen throughout the whole life. Old age hearing loss, where the cochlear blood supply degenerate, and then it starts to become weaker. But when you have diabetes and hypertension, definitely you're going to lose your hearing. And it's where you find that the grandparents, they get very angry when you talk because they can't hear you. You know, they want to play with these children, the grandchildren, but they can't hear anything. So when they come to me, I do all the assessment. I said, hey, grandpa, your batteries are flat. We need to replace them because they will be flat. As much as now, my batteries for my eyes are flat. I need spectacles even to see how things looks like. So, and then you can get another one where you have what we call sudden sensory hearing loss. So it's just like a stroke. So you just wake up and say, today, this morning, on the 12th, I woke up, I cannot hear and I cannot understand anything. And you remember it precisely. If that happened, make sure you see the doctor within 3 days. Beyond 3 days, you are lucky if you still have 7 days. But if you go more than 6 weeks, 3 months, and a year, we can't do anything. So that is a stroke of the organ of Corti. It just shut once. The person will tell you exactly an hour and time and day. Make sure you see an ENT within that time, or see an audiologist, and the audiologist must refer you immediately to the ENT to confirm that your hearing is gone.
Prof, Louis, as much come so there was a very light thing.
It's like light.
Light thing. So
they will tell you exactly.
Yeah.
Yes. They'll tell you exactly that time. They know the hour. So is a time, is a place, is a date, and the amount, because they can tell, look, I can't hear, you know. And once they start to have ringing and have nausea and vomiting, then we know that the cochlea and the balance system are all knocked at the same time. And once you have a ringing and a balance, that hearing is difficult to restore. If it's early, we try different medication to try to get back, and some they might be lucky and they recover.
So, Mr. Joseph, we see the lifestyle of our teenagers, our youth. They love where they go, there's music, loud music, there's noise, and they do that thing. I don't know what is it. That thing that they love. It doesn't happen. The lifestyle of our youth. What can you say about it?
So, yeah. I think over the last couple of decades, our environment has naturally gotten louder. We're not even talking about lifestyle choices, just the environment. We're busier, there's more vehicles, we're more cluttered together in cities, we're more exposed to lots of noise. That alone places us at risk for damaging our inner ear. Okay? But then what's happened recently, as we've moved to social media and all these little technologies and earpods and stuff, the problem is we understand what noise is. If I tell you noise will damage your hearing, you understand that. And you say, yes, but I don't use a drill, or I don't use a machine, or I'm not working in a factory. But the ear doesn't know that that's a drill noise, or that's a music noise. The ear says, it's above 85 decibels, it's harmful. It's damaging me. And the problem is we regulate noise in an industrial setting or an occupational setting, but we recreate the same levels of damage with these little earpod thingies that we put in our ears, with these nightclubs, with these big speakers, and we're actually exposing ourselves to what we call harmful noise, and we're doing it recreationally. And as I think Prof mentioned earlier on, the level of hearing loss is predicted to increase dramatically over the next 20 to 30 years. And we're starting to see it. In my practice particularly, I see a lot of people who were professional DJs and musicians in the 90s, when it was the heyday to be traveling around playing loud music. And now that in the late 50s, early 60s, we do hearing tests, and yes, you've got a hearing loss, but it presents as a noise induced, and noise creates a specific pattern, and we can pick up that pattern 30 years after you were a DJ. Now you're working as an accountant, but you were a DJ in your 20s, and boom, that ear is damaged. So noise and environmental sounds is a big thing, and I think this year's theme for the WHO World Hearing Day is to live in a less noisy environment, to prevent yourself from damaging your ears. Okay, that's noise. But then there's a whole load of other things. We speak about ototoxicity, but there's recreational drugs that also damage our hearings. All these stuff that kids, and sometimes not even kids, some older people also take recreational drugs. Caffeine doesn't seem like a problem, and it doesn't directly cause hearing loss, but it prevents the ear from recovering from damages that noise can cause. So it slows down your recovery from a temporary threshold shift or temporary hearing loss. Then there's all sorts of other things that we take, supplements. Some people take supplements for all these dietary fads. Nobody reads those supplements, and you don't read what those interactions can do to your body, what it does to your circulation, what it does to your glucose levels, what it does to all the other things that, as Prof mentioned, you only have a little bit of blood supply. Anything that affects the quality of your blood finds itself concentrated in the inner ear. And that is why patients with, and even now, again, back to lifestyle, our diets, we've seen an increase in patients with diabetes. Diabetics, research has proven, are twice as likely to develop hearing loss. And those are the type of lifestyle issues that we're going to start seeing going forward. The fad diets, the noise exposure, and all these other substances that we are starting to ingest. In the next 20 years, we're going to see a shift in hearing loss where people are presenting much younger than currently. I mean, now you'd identify a progressive hearing loss in a natural aging setting, 65 onwards. We're probably going to start seeing it well into the late 40s, probably maybe even sooner than that going forward.
40s is too early. The biggest problem, I hope I'm not going to be fired by this company, is cell phone. Radio frequency. And when you put the ear pod, the whole sound, it does not leak, it goes into the inner ear. And studies have shown that if you can keep the ear pods or the sound in your ear for more than an hour a day, you start to affect your hair cell and you lose your hearing. And imagine when you do one call with this thing in your ear and you are talking. So most youth, they spend more than 1 hour a day. And the sound, you and me, when we talk at the region of 60 to 65. The sound, anything above 80, most of the cell phone, they are 75, 80 and above. And when the noise induces heat, they keep that thing louder. So, and they come to you now, and the radio frequency is one of the things. So they get radio frequency from the phone, then they put the loudness higher. So as early as 20 now, they are starting to present with a high frequency sensory neural hearing loss because they don't rest the ear. Some I tell them that use a speakerphone, put it down and talk. Don't keep on. And after you've used the phone for too long, you feel the ear is hot. Imagine that you're cooking there.
Because it doesn't look cool. On a speaker, like the phone on a speaker, like that. And if I'm living, lately there's this
Beautiful
gadgets that I put on this, and I'm just walking
at the gym. You had the gym at the gym.
It looks cool, and I think that is the problem. How do we educate our people to understand that yes, it may look cool, but there's danger along the way.
I commend this program and I commend my doctor, Prudence, that what you're doing is very good because education. So the more you know what to do. And if you're genetically predisposed, yes, you might knock your hearing early. I'm starting to see them early. Some of them, they cannot work, let alone if they are in the switchboard. Then they are losing their job in the switchboard because now they can't hear. The boss gives them the instruction, then they can't hear the instruction. The other worst thing that you're going to be shocked, let alone now with the virtual thing because of COVID. Everybody put earpods, they are watching. So how many hours a day that you are exposed to a loud noise in a tight space? In a tight space.
Am I allowed to ask a question?
Yeah. You are part of
But you can ask. Because we're seeing those questions.
Yeah, Prof. Look, like I said, I work for a drug development company. It's a multinational company. It's been more than 15 years that I work in that environment. So I've been working from home. Every day I've got 2-3 times meetings, like a day, and I have to put my headphones all the time. So I'm worried. I'm very, very worried. You depicted something that I was ignoring, which was going to be a problem in the future. So apart from not using the headphones and putting everything on speaker and so on, is there any device that can be used between those earphones and my ear that can minimize the impact or something?
I'm not aware of it, but I know that when they go to the mine, even those ear plugs, they don't work. It's just waste of time. And the other thing is what I wanted to mention with the sound and thing in the ear is that so people start to have headaches, then they start to lose concentration, then they start to be irritable, they start to be moody, they start to feel pain on the neck, and then most of them they go to psychologists and psychiatrists and neurologists because that is a radio frequency. Some frequencies are going through the hearing system is a nervous system. So now you're pumping it with because immediately when the sound comes in decibel or in volume, it goes to vibration in the middle ear. When it goes to the inner ear, it's an electrical system. So you can't keep on doing that for too long. So after some time, so for a person like you who are doing that, see him, let him do the test. Luckily, it hit the higher frequencies that you might find that you don't enjoy your music anymore. So when you start to go to 6,000 kilohertz and above, and 80 and 20, those are the ones that they hit first. When they've hit everything, then they come to the normal, frequency that we speak, which is around 3 to 4 kilohertz. That we from 250 to around 4. That's where we speak around that. But it is a problem. So you find that after you've been on that thing, you're irritable, you're angry, you can't sleep, you're tense, And it's part of lifestyle and what we're doing, unfortunately. And if you have COVID infection, because we know that COVID causes sensory neural hearing loss, it has been proven. It causes vertigo, it causes you to get dizzy, it affects the whole system. So imagine now you have COVID infection, now you put the sound, you have other comorbidities, you are in trouble, and you take his motives. But I mean, the lesson is that watch yourself and listen to programs like this, and when you feel something is not right, go to the right people. Don't just go to the doctor because say he's a doctor. There are doctors, then there are doctors. There are audiologists and there are audiologists. There are ENTs and there are ENTs.
Okay.
And there are sign language and there are sign language. So you must know.
We get it.
Yeah, and you
Same
people,
as pharmacists.
exactly. And you don't tell you people you are smart. No, if I go there, if Dr. Prudence gives me an opinion, it's a real opinion. And if so and so give me an opinion, I'll take it with a pinch of salt. I'll go to third, fourth, fifth opinion. Before I actually said, okay, I can take this. When we were young, I'm not sure not to waste time. We used to ask, when did you qualify? Don't know when you qualify, Prudence. So there was some university where we know if you qualify in that university, I'm not going. That's why. No, I can't consult with you. So age also helps, and the way you qualify also helps, because you start to know in that university, you know, some of the degree you hold, it's not really worth it, and the paper you have. I get people fight me on social media when I say, I can't be a professor and I don't prophesy. What is the use? You know, I can't be a prophet and I don't prophesy. What is the use? So you can get a title, but the title does not mean you can deliver. So you must know where, if you're not happy, please go to the person who will give you the opinion that will help you in your life. So my friend, you must go to him to do a regular checkup and see.
Will do.
The way I can afford is feeling to get we need to be careful. But importantly, let's be cautious on, I think all the people, our panelists, have indicated one thing: get a professional opinion. And Prof said, get a professional opinion and a professional opinion. Yes. That is very important. Very important. But for actors, I'm sure Josias he's a very technological person. He deals with tests and stuff. But I'm thinking, what you were saying, it's not a qualified opinion, it's not a professional opinion, but I believe that people these days would put or buy a little bit speaker to enhance the sound of the computer, but which they are able to put a little away so that you're not putting something Maybe in my thought process says it might be quite useful. And from what you were saying, pick up the whys, that it's a real worry now.
It is.
You grow up, the world has turned around and made you to use this thing almost every day. The meetings that you're talking about might be daily occurrence. Because
it takes hours,
You're taking hours and hours. And I think let's take care of ourselves. Let's take care of our health. We want to grow up and be like Prof. Ichim we were celebrating his birthday yesterday. So 88. So we want to grow up and be that and be useful to our community. Run programs like this where we are educating. Today I've learned. And the way it's not just a smakwam. It seems like an important organ on a number of things, to an extent where we need to prevent this from happening. I know Joseph's people are the kind who do speakers, which speakers on the radio,
our colored brothers.
When they pass you, you say, "It is not loud to you in your car." What about him in his car?
So these are some of the things that young people will be fascinated about. It looks cool, but we are saying, if you have listened and listened carefully to our experts, people who are in the field, who are dealing with these things on a day-to-day basis, please note and make sure that when you go to the relevant people, you ask the right questions. You take some information with a pinch of salt, like Bob says, but some you can hear that it's actually designed to help you as a client.
Wayibeka lo ngaphambi kokuba sivale sisikhethe ukuthula ngifuna uku-understand la for it's a caring week our this week umuntu onjengami ongayazi sign language ongakwazi ukucommunicate nabantu abangakwazi ukukhuluma abadala uthi yini lo ufuna sibe awe ngayo
ukuthi kumele nifunde sign language. Like just go out there. There are apps that you can actually download that can teach you signs, and then there are schools for the deaf that teaches sign language, and also there are YouTube. There are so many videos on YouTube. Just make sure that it's South African sign language. It's not American, because the signs will not be the same. No, it's not universal, and there's no Xhosa Zulu Afrikaans sign language. It is just sign language. South African sign language, and there's American sign language. So some of the signs, like I'll say toilet, but then in America this is name. Yeah, like your T, like the other T. So our T is like this, and then your T iyatugana angengwazi ukuyenza eTV. So you're danger, but in America that's a T. But in South Africa, that's a swearing sign. Yeah. So, but just go to just YouTube. Actually, try and learn few signs, and then how to then incorporate them into like a proper sentence. And again, the structure. Remember, the structure is not the same as English. It's not the boy kicks the ball. It's boy ball kick or kicked. But then in sign language, you don't have about ED, we don't have about ING, we don't have like most of the things that we have in English. So just that people use English to learn, so then it confuses them. Yeah, so because mostly the writing between you and the deaf person might not work because of the education again. But we have wonderful schools that are doing amazing things, and we have deaf people who are actually making it and going to universities. But just make sure, remember that when they write, they might not write in English. They're writing English words, but then the structure, you might not understand exactly what they're saying. So you need to take your time and, analyze,
Am I allowed to ask two questions? The first one is simple. The second one might be complicated. With the blind, they have a stick.
Yes.
But with the deaf people, you don't know if this person is deaf. And I was once caught, in my practice. So when you talk to the patient who's deaf, they speak very loud, or they look straight in your face, not because they are confident, they want to lip read. So when you have a mask, they can't see anything, then they get confused. So do you have anything generally for the deaf patients or deaf people living with deafness to show that this person is deaf?
We don't really. No, we don't. Then only when you start talking to them, then they will know. Then they will tell you, I can't hear. Then you know the person is deaf.
Which usually confuses. But the other thing when I watch on TV, which is fascinating, I always find them very aggressive. I said, look how they are fighting. Is it how you talk?
No, it's just
you don't find them, gently. They are. Because they are doing karate.
No, like no, it depends.
That's what I see.
No, and that's the people say that a lot. The deaf people, they gossip and they're always angry, and So when you in a community that does not understand you, that does not understand your language, and you're trying to communicate and nobody hears you, you get a deaf child in a family of hearing people. Everyone is just communicating, and then out of the blue, "Kwa, kwa, 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 kwa," they are there. Nobody tells them what the joke is about. Obviously, they'll withdraw themselves. So, and it comes to the point of signing on TV. Normally, the news anchors are very fast. So when you're signing, you have to be quick as well. And again, you have to, what's the word? You need to match the person talking. So when the person is lively, your signing should, because you become that person who's talking. So when the person is, like our former president, Jacob Zuma, so when you're signing for him, you need to be very slow, and, your signing is, it kind of matches his way of talking. So when you see them fast, they're just trying to keep up, because in your brain, apparently they say there's like 32 processes that happens per second when you interpret. From the time you hear, you store, you're processing, you're analyzing. At the same time, you're looking at your hands and what you're doing. But it's just an amazing, amazing field. We need more people.
It's quite interesting to go to this show, Angela, because all of a sudden it now makes sense, because with TV, with radio, whatever that people are doing, that they are screening, so obviously it now makes sense.
Yeah.
Now it makes sense. It was not, and it looked like it's Prof alone. But I'm sure many of us who were sitting would have been feeling the same thing. Hey, I saw, push it.
Before we close, there's something that I want us to cover, Josias. When we talk about this occupational noise, when I'm working in the mine, when I'm working in the street with the driller there, and it's affecting my ears, and I end up not hearing, these people, they can go back and sue the work. What are the work policies or regulations or the laws about that? What are they supposed to do? Because I heard about that even what they put for years, those who are working in the mines, is not working exactly. How are they supposed to protect themselves, even the employer, so that they don't get back to be sued? The same as using, giving a patient streptomycin or other TB drugs, and then they end up not hearing. Then they go back and sue the hospital. How can we protect the hospital or against the patient? What's the law saying about that?
Okay, so it's two separate things.
Yeah.
I think back to we'll start with the streptomycin thing. The streptomycin thing is regulated by the HPCSA, which says you need to have proper express consent. And if you do that and you tell your patient, we're going to administer this, it's going to save your life, but you may end up with a hearing loss. You're protected. They can't say. The problem is sometimes in our urgency to treat the one condition, we overlook the patient's right to actually know what you're doing. And that sometimes becomes, because then the patient says, you know what, I went in for TB and then I can't hear. Nobody told me what happened. Then you open yourself up for litigation, and it becomes a big problem. So as long as you stick to proper consent, engage with your patients, explain to your patients beforehand, and make sure you explain in a language that they understand. It goes back to people that are deaf sit in your practice. You don't know how to explain to them what's happening. So you say, oh, but he couldn't hear me, so I just did what I needed to do. They still have rights, and you still need to be able to ensure that they know why you did what you did, and that can become a problem. So it's very important for us to realize that not everybody understands things in the same way. So make sure your language, your explanation is at the same level of the patient. That fixes your whole negligence claims. On the employment side, on the occupational side, the entire process is regulated by the Occupational Health and Safety Act. And it basically says that if sound is above a certain level over a 8-day average period, these are the things that needs to happen. You need to monitor the sound. So the company can't say it's noisy, but not know how noisy. They need to have a professional noise survey done. It needs to tell you this machine operates at this type of noise. This is how long it operates. This is the risk. This is what we can do to prevent it. Because in a room like this, you're going to get a lot of reverberation. That noise is worsened. But if you do a proper survey, they can say, oh, but we can put a panel here. We can put a screen that protects the employee from the sound. We can do sound dampening processes and things like that. Then based on the levels that you determine, then you choose the correct ear protection. And that's what Prof alluded to earlier. Those tiny little ones are good for certain sounds. But if you're exposed to high levels of industrial noise, those things aren't able to suppress that level of sound. That's when you need to use the big supraoral earphones type of setup that dampens a lot of sound. And sometimes sound is so loud, you need to put the insert and then still put the additional earphone just to protect. And the problem is, one, we have a lot of companies in this country who don't care. They just simply don't care. They just do it, and we've been on sites, we've tested people. You go back, all the paperwork is done. So they follow the law. You're supposed to have an entry exam, you're supposed to have annual monitoring, you're supposed to have all of these processes. They've got it. But from 2012 till now, the results show that the patient's hearing has been damaged. But the law doesn't say do the test. The law says monitor. The law says protect. There's a whole other things that you're supposed to comply with, but they say, oh, but I did the test. But the test said that your noise is damaging the person's hearing. And that's when companies become open to risk of IOD type of claims, because now you can prove, I went in with normal hearing, this machine was so loud it damaged my ears, and now I come and sue the company. And, you know, to some extent that's perfect. You cause the damage, you should be held liable. But you can never recover that hearing. So that little bit of money that people get out doesn't make a difference, because they still cannot function in a fully integrated society, because sometimes some of this noise is so high that even with a hearing aid, you don't have proper functional hearing. And now you're not so old that you have to retire. Some of them are in their 40s. And you cut off the world because you worked, and in most cases you worked in a poorly paying position. So you never, it wasn't worth the sacrifice that people do. And I think at this point in time, unions, people that enforce all these legislature, the Department of Labor needs to be a little bit stronger in terms of how we police this sector, because we are going to, I mean, a large percentage of our population is employed in mines and industrial settings. That means we are creating widespread man-made hearing loss, and we've been doing it for decades. It's a silent pandemic, and it's probably as goes back as long as we've been having mines and construction and things like that. Nobody's done enough to monitor it, and that becomes a problem.
Can you just tell us, as an audiologist, how do you treat hearing loss?
So it depends. If you have an outer ear or a middle ear hearing loss that's caused by a specific pathology, we refer, and then Prof would go in and say, this is an infection, this is what we do, this is the surgical process, this is the medication, and then we'd manage it as a team like that. In the process, we'd also monitor the hearing and send results to and fro, so then we can say, the grommets actually worked, the child's hearing is better. In other types of hearing loss where it's more permanent in nature, where surgery or medication can't help, if there's functional hearing, then we would use a hearing aid. It's a device that People just think it's like a speaker, just makes things loud. But hearing aid technology is very, very complex. The hearing aids are able to analyze the sound and produce an output that matches your hearing loss. So it works in conjunction with the hearing test results that we put in, and it makes sure that you're able to hear in a more balanced perspective. Certain other types of hearing loss, especially if there's ability to develop or to maintain communication, then we'd again refer to Prof and ENTs, and they have a little team where they do cochlear implants and those type of things, where they can maximize on whatever's left there. They do surgical processes that's able to produce the ability or reproduce the ability to hear. And then if in some really bad cases, there's not enough functional hearing. So you'd go in, you'd probably use a hearing aid so that they get some environmental sounds. You want somebody to be able to hear if a car is hooting and things like that, but they may still not be able to pick up speech. That's when you supplement it with sending them to facilitate learning lip reading and visual cues, and if they're young, sign language as well.
I wanted to mention about occupational hazard, and also the occupational hazard, it's not even easy to get some money out of it, because the ruling is very strict. The percentage loss that you need is so tight that you really have to have completely dead ear. I had a story, if you allow me to say here, a guy who did engineering and is qualified, he has been looking for a job everywhere, but every time before he goes for his engineering, they do a hearing assessment, and every time he's failing this hearing test. And all his life, he never knew that he was deaf. I had to motivate and write a letter to the management to say, look, this guy knows he's deaf, this is his baseline, but he's an engineer, otherwise he will never work. Luckily, of course, it depends who is speaking. So I said, look, I can vote for him, and he is prepared. He needs a job. He's young. Then they accept him on that. He came with his weak hearing, but he's nicely functioning with one engine. So anything that will happen thereafter, we will know. Otherwise, that guy could not work with a degree in engineering, in mining. So that's why it's always important to have a baseline to know where the person is. So like, as I say with him, he might be losing his hearing and he's not aware. So the baseline is very, very important. Imagine you finish a degree of mining engineering, you go to all interviews, you have everything. They say, okay, now let's do a pre-employment test. You fail. They say, we can't give you a job. And the guy come to me crying. He said, Prof, I don't know what to do. I said, in my language or in my life, we can do something. Let me talk to your boss and tell them that, no, look, we know he's functional. That's what I said earlier on. You can have a hearing loss, but you're functional. And then you can have deafness where you're disabled. So sometimes you can deal with an issue as an individual, even with deafness, but you must try to help the patient when they've come to you and see what else can be done. Because once you say, there's nothing we can do, you have destroyed that guy. He said, I have a family and I have a degree, I spend all the money, now I can't work. And I'm happy that they end up accepting him and they appointed him based on that.
So, as you are one of Prof that are worldwide known about this operation that you are doing, can you just take us through? What are you doing? Can you treat even those who are born with deaf? Or can you mentioned all the
you mentioned, yes.
Can you just touch all your treatments, but the one that made you to be well known about it?
Yeah, the one that makes me to be worldwide, international, Wikipedia, Google, everywhere you go. I'm the pioneer of the middle ear transplant and replacing all those 3 bones with a 3D technology, fully as they are, and nobody has done it. 2019 and now, nobody has challenged me. So we are in the process of doing clinical trial so that, when you do a first op, like you were saying about clinical trial, so that it will be a standard acceptable operation. The ones that we're using now to replace the broken bone, they don't last long, and they break and they fall, and the sound I can give you can only achieve 75-80% of what you have lost. They are very unstable. So this one now will take an X-ray of Dr. Buthelezi, and then we see how those bones looks like. Then we go to the computer create them as they are. When they come, is Dr. Buthelezi's middle ear ossicle. So we are working on getting all other things. I can't say some of the things because it's like a Kentucky KFC. but that will what we are checking, Josias, is that will improve the sound and the stability of middle ear loss by far. But not only that, once that is there are other things. Maybe we can even put hearing aid, this middle ear implant, where you can have something in the middle ear but nobody can see. Because they are also working on totally implantable cochlear implant. The problem is that here's the battery that you need to work on. So I'm pioneering that. I'm in the verge of doing that research. And then the good thing, 3D, is quick. We can just cook them overnight. Have an X-ray, put them on the computer, and then when you wake up in the morning, Mashudu, doctor, so and so, and so and so, and then it will be easy to put it. What we have now, if you see them, I tell my son, I said, I feel ashamed when I put this operation sometime, because the old one, because I said, truly in this advanced stage with fourth industrial revolution, like you mentioned, 4IR, that the hearing aid is no longer just box. They are more advanced that they can tell you, are you in a stadium? Are you on one-on-one? Are you listening to a movie? Are you listening to music? And then you use a Bluetooth on your phone, and then you set it the way you want. Are you in a classroom? So they're very advanced. Of course, they need money, but there's a lot of advancement in that area. So my pioneering the middle ear, I'm put next to Chris Barnard. So Chris Barnard and me, students at school, they're learning that. So they're learning that there is such a thing.
I think we do
No, but South African are innovators. That's why I said all our problems we must believe in ourselves. I think that's what
there's one important aspect that, as you were talking about this innovation and open goals, I realize we might not have spoken much about it, but this is a country that is, if it was a disease, we'll say it's infested by traumatic injury through road accident and stuff. How much of people do we miss to attend to ear issues? Because often they will go get operated to try and fix the brain, the bones, and they throw them.
And then they later on,
only
they just
it
doesn't hear.
Yeah.
Then only then they realize that.
And the difficulty that it brings, because when you want to rehabilitate this person physically, because you don't know that they can't hear, you think it's just brain chemicals.
The patient that I implanted in 2019, he was about to be fired at work. And it's after we have tried with the normal, whatever existing middle ear processes, the total ossicular. And they were not working. So I told him, look, I'm working on this thing for the past 10 years. Will you be willing to be a volunteer? He said, no, by all means. And the guy agreed. And then from there, he went back to work, and he's the most exciting guy you can ever find. So he has to take it to the masses and everywhere. I get phone from all over the world, including America. The guys, they said, please, Mashudu, want to come. all over the world. I said, we must do, but I mean, so my career is still to deal with middle ear hearing loss rehabilitation. Not stealing from his hearing aid, because he'll be worried that once I do that, now he won't say yes. So what you do
That's
with
the interdisciplinary aspect.
yeah, fortunately, Joseph, he understands that.
Because I think that's one of the education or takeaway that we want people to have an understanding in,
Yes.
is that it's not just one professional.
Yes.
This thing is so interlinked. I mean,
Yes.
today I'm learning that the pharmacist would be as much important in noting some of these things to say, Murena, you've been taking this for too long. Your hearing might be coming from the fact that you've been taking this for too much.
The same like malaria prophylaxis. So you take malaria prophylactic drug, they will tell you, these guys, that malaria prophylactic drug, yes, you won't die from mosquito bite, but you might lose your hearing. Fortunately, it's also temporary.
Yeah, fortunately, yeah.
Fortunately, so it will drop it a bit,
Yeah.
and then later on it will come back.
And they can be advised also on which malaria treatment or
Safer
prophylaxis are
ones.
safer compared to the other ones. You know, you can assess based on the age and based on other, comorbidities and other drugs that they are taking as well. So, yeah.
Now, that is the problem, and I'm seeing a whole lot of things, and I'm sure you can see how important Somtakaro is. So when you go back to your company, you probably will tell them, we need to sponsor this. They're doing great work, of educating the public.
Yeah.
Everything, health, education. We will bring it to you, bring you in the best in the world. Professors looked after him. Just anyway, I'm training India, China, whatever. Before you know it, you will have a call from Xi Jinping from China.
No, I have calls from India. They wanted me. They said, money is not a problem. We'll fly and come.
Yeah.
Sure.
Because when they see, they know that what the ENT are doing in their country, they cannot do what I'm doing. So, I mean, all Europe, I mean, UK, everywhere, including Australia.
Starting in South Africa, we are the best in Zomtaka. Then we move to other people benefit from it.
City Gauteng, TB, nayo kuzoba lapho, ENT. So ngiyamthola lapho every Sunday.
Sunday, usually I'll be doing the preaching, but I will also be doing some health talk, more in detail on the other different conditions in ENT head and neck.
Here the facility, preaching. Past.
Yeah.
So Sunday you find me when we are operating the divine intervention.
I miss when ngafunda kabanzi ngokuzwa nokubaluleka kwendlebe yethu nisale kahle bana leli nababukeli lapha emakhaya siphinde futhi sitholane next week.